Welcome everyone to the 2022 Head and Neck Cancer Survivorship Symposium developed by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session is Head and Neck Cancer and the Importance of Comprehensive Rehabilitation. My name is Dr. Vilia Vititis, and I'm an assistant professor at LSU's Department of Otolaryngology here in New Orleans. I want to thank our medical panelists, Dr. Michael Stubblefield, Colleen Dunphy, and our Head and Neck Cancer Alliance ambassador, Cindy Stemple, for presenting on this session today. To begin, I'd like to provide a few brief introductions of our panelists. Our survivor panelist, Cindy Stemple, is a formerly trained and avid singer who is now a two-time oral cancer survivor. In 2015, at the young age of 27, Cindy was diagnosed with stage 3 oral cancer and treated with surgery and radiation. She later was diagnosed with a recurrence in 2018 and again underwent surgery. Today, we are fortunate to have Cindy on our panel to discuss her experiences with physical therapy and speech therapy in both of her recoveries. She's undergone physical therapy focused on increasing her strength and flexibility in her neck and jaw, as well as her post-lymphedema therapy. In addition to physical therapy, Cindy has had extensive therapy with both traditional speech pathologists and specialized speech therapists to rehabilitate her speaking, eating, and singing capabilities after surgery. We're thankful for Cindy being here today to share her story. Our second presenter is Dr. Michael Stubblefield, and he's the medical director for the Cancer Rehabilitation for Select Medical and Kessler Institute for Rehabilitation. His clinical expertise is in the identification, evaluation, and rehabilitation of neuromuscular, musculoskeletal, pain, and functional issues in cancer survivors at any stage of their journey. He is particularly interested in managing complex issues resulting from radiation therapy in the head and neck cancer survivors. And our third presenter, Colleen, has spent 13 of her 16 years of physical therapy practice working exclusively with people with cancer. She is the secretary of the Canadian Physiotherapy Association's Oncology Division and is the Canadian liaison for the World Physiotherapy Subgroup for HIV/AIDS, Oncology, Hospice, and Palliative Care. She lectures in palliative care at the University of Toronto and is currently completing her Doctor of Science in Rehabilitation and Health Leadership through Queen's University. Her dissertation focuses on the educational competencies needed for physical therapists working in cancer rehabilitation.
Hello, caregivers, support people, and fellow survivors. As previously mentioned, my name is Cindy Stemple, and I'm a two-time young adult survivor of stage 3 HPV-negative oral cancer. A condensed version of my story is that I was diagnosed at age 27 after finding a sore on my tongue that did not heal after several weeks. Next slide, please. Well, cancer is a devastating diagnosis for anyone. Oral cancer was particularly traumatic diagnosis for me because I'm a trained singer. I received my Bachelor of Arts in Music Business, and while my career ultimately focused on the business part of that degree, I have been an active member of the local music community and have been a member of several choruses starting prior to my diagnosis. I faced a lot of challenges during my treatment for that initial diagnosis, but I particularly struggled a lot during radiation therapy and ultimately ended up needing a feeding tube for nutrition temporarily. I also experienced some long-term mobility challenges, difficulty opening my jaw, as well as lymphedema, just to name a few of the more common side effects I experienced in the weeks and months after radiation. At the time, I was referred to several different therapists and specialists to help me manage the side effects of treatment. I saw a speech pathologist to help me manage my swallowing difficulties after treatment, in addition to working on my speech and range of motion in my jaw with the goal of being able to sing again. Once I started to see some progress with a traditional speech therapist, I also saw a second speech therapist who specialized in helping singers adapt to the changes and side effects of treatment. I also saw a physical therapist for interventions for my lymphedema, as well as assistance with regaining some of the strength and mobility in my neck after surgery and radiation treatment. Unfortunately, a couple years after my original diagnosis, I experienced a recurrence, and this time needed to have a free flap reconstruction after significantly more of my tongue was removed. After that surgery, I saw the same speech and physical therapist to help me learn how to control the new flap to manage eating, speaking, and singing, as well as address many of the same lymphedema and mobility challenges I experienced after my original diagnosis that reemerged after the second surgery. I also needed physical therapy this time around to help me regain strength and dexterity in my arm and hand due to the tissue that was removed for the reconstruction of my tongue. These comprehensive therapies and physical and speech therapists who help facilitate them allowed me to achieve what I feared would be impossible at the time of each of my diagnoses. Next slide, please. Within 4 months after surgery, I was performing in our chorus's spring concert, and at Christmas time, approximately 10 months after my 3-flap reconstruction, I performed as the alto soloist for several performances of Handel's Messiah. While regaining the ability to sing was my highest priority after cancer treatment, physical and speech therapy also made it possible for me to finish my MBA, jump out of a plane in a tandem skydiving trip, go rock climbing in Rocky Mountain National Park with an organization called First Descents, who sponsor adventure trips for young adult survivors, and enjoy many other pre-cancer hobbies like playing golf with my husband and our friends. Next slide, please. While I'm thrilled I've been able to achieve such a wonderful quality of life after all I've been through, treatment in the subsequent years have not always been easy. So I wanted to share with you a few things I wish I had known during the process and after treatment that would have helped me throughout. First, don't downplay any side effects you're experiencing during treatment, and share with your doctor any new symptoms you never experienced before cancer. There were several issues I encountered along the way that I didn't immediately realize were side effects until I spoke to my doctor about my concerns. It took me a long time to realize that there's no need to be stoic during and after treatment. And raising these concerns with my doctor allowed them to refer me to the specialist who could help me or recommend potential new treatments or trials to manage some of these side effects. Second, it's never too late to seek treatment for your side effects. I just passed 4 years in remission earlier this year, and I'm still working with my radiation and surgical oncologist to help arrange the best maintenance schedule for physical and speech therapy to help manage some of the ongoing issues I continue to experience. Just because treatment ended months or years ago doesn't mean that there aren't still therapies that can help you. So continue to raise any issues with your medical team well after treatment has ended. Third, you may not see instantaneous results when you start any of these therapies. And one of my speech therapists recommended I approach the process with the mindset of just doing a little bit more than I was able to do the day before. For me, some days this truly meant eating 6 bites of applesauce that instead of the 5 I had managed to eat the day before. It really can feel that slow, but those little things will add up a lot faster than you think. And I credit this mindset with how I was able to go from really being bedbound and on a feeding tube to singing and performing within a few months of my surgeries. Fourth, ask questions. I remember being afraid at the start of treatment that my questions were stupid or that I would sound unintelligent. And I had the feeling that I thought I should be able to find the answers on my own. It sounds a little bit cliche to say, but especially when you're someone like me who had never been close to anybody experiencing a cancer diagnosis or treatment before my own, you don't know what you don't know. There may be a lot of options for therapies you never considered that your oncologist can recommend, but the best way to find out all of your options is to ask any and all questions that you have. Finally, find a community of other survivors or caregivers, if that is your role, to connect with during and after treatment. It wasn't until well after my first diagnosis that I started connecting with other survivors on social media, and my husband started connecting with other caregivers. I cannot overstate how helpful it is both physically and mentally to turn to others who have been through it for support. Social media especially can be a great tool to find others who have experienced similar side effects and hear what has been effective in managing them. Immerman's Angels is another organization that can help you connect with other survivors. And there are a lot of resources on the Head Neck Cancer Alliance webpage, or you might consider asking your oncology team if there's another patient who would be willing to connect with you and share their experience. After my second surgery, my surgeon reached out to me and asked if I would be willing to do this for another young patient undergoing a similar surgery. And I was happy to answer their questions and share my experience. Cancer is one of the most challenging things someone can experience in life, and finding others who have been through it, either as a patient or a caregiver, to connect with and support you can make a world of difference, especially during the moments of treatment and recovery when your regular support system may really have a hard time understanding what you're going through. Treatment for head and neck cancer and the subsequent side effects are one of the hardest things I have faced in my relatively young life, but I really hope that my story gives you hope that a great quality of life is within reach after treatment has concluded with the help of physical, speech, and other complementary therapies. And I'll leave you with my wish that I hope you have the best experience you possibly can as you continue your journey through treatment and survivorship.
Wow, I really want to thank Cindy for that absolutely inspirational story. I'm Dr. Michael Stubblefield. I also want to thank Dr. Ville and Colleen and everybody else who made this possible, and of course all of you who are taking your care and survivorship into your own hands. So what I want to talk about is some of the functional impairments in head and neck cancer, sort of how you get them in very quick terms, the sort of things that we can do with them before I turn this over to Colleen. Next slide. So those of you who've lived through this, certainly as Cindy knows, the treatments vary, but it's surgery of various types. Some of you have been unlucky to have multiple surgeries. Systemic therapy, meaning chemotherapy and now biologic therapies of various types, and the gift that keeps on giving, which is radiation therapy, which I'm going to talk about in some detail. Next slide. So the surgery really depends on where your cancer is, what type it is. Some people will get neck dissection, some won't get neck dissection, some will have reconstructions like the flap that Cindy describes having. It really very much depends on you, your cancer, and a variety of other things. The surgery is very debilitating, but again, it's probably the radiation that is the biggest limiter of function and quality of life in head and neck cancer survivors. Next slide. Now, radiation is really just light energy, right? We're recording this Zoom with relatively low energy, thank goodness, radiation. But radiation used at very high energy can kill cancer. It also kills normal body tissues. Next slide. So the idea is that we use radiation in head and neck cancer coming from multiple directions. We call this intensity modulated radiation is the normal dose. And we give doses that are high, right? So up to like 70 gray, 77,000 centigrade, sometimes even a little higher than that, sometimes a little less, again, very much depending on the cancer you have. But we give that radiation to a very important part of your body, meaning the tumor itself in your head usually, and then all of those lymph nodes in your neck. And as you can kind of see in this drawing, there's a lot of important stuff in there. The spinal cord, the nerve roots coming out of the spinal cord, your brachial and cervical plexus, a number of peripheral nerves, a number of muscles. All of that is right in this high dose radiation zone. And because of where they are, even though you're going after the cancer, even if you're using, the latest and greatest techniques, all of those structures are still very much there. Next slide. So what that causes is something called radiation fibrosis. So radiation fibrosis is the slow hardening of the tissue that occurs over time. It's time dependent, meaning the longer you're out from the radiation, the more fibrosis you're potentially going to have. That fibrosis does a number of things. One of the things is it kind of cuts all the tissues off from their blood supply. So they literally are just deprived of oxygen and other nutrients. And if it goes long enough, can die as a result of that. It damages every tissue that's in the field, but to varying degrees. That means it's damaging nerve, muscle, bone, your lungs, which are often in the field, at least partially, the heart or the great vessels like your carotid arteries, which are in the field. So radiation fibrosis syndrome, which is something some of you may have heard of, are all the bad things that happen to you as a result of the radiation. And again, they are very much time dependent. The longer you're out, the more likely you are to get these issues. Next slide. So the things that determine if you're going to get radiation fibrosis are many. So one is the total dose. So in breast cancer, we generally use about 50 gray, and it's really confined just to the breast, although we may do the axillary lymph nodes, and there's a number of nerves there. But in head and neck, we're using 50 gray and up, even up to 70 gray of radiation. So it's very high dose. The size of the fractions is important. Here, the fractions are usually about 180 centigrade, 200 centigrade, so not huge. Your other cancer treatments, meaning the surgery, the fact that you had a dissection and all of these tissues may have been damaged from that certainly impacts it. The fact that we give you chemotherapy may absolutely impact. The type of tissue, so lung is very sensitive to radiation. Bone and nerve is actually less sensitive to radiation, but still can be affected. Protoplasm, that's sort of a tongue-in-cheek description of your overall health status. Do you have diabetes? Do you have severe arthritis? Do you have other issues that are going to make you more likely to do badly if you get radiation? And then, as I keep saying, time. Radiation is the gift that keeps on giving. You have that sort of acute, early, right during radiation treatment issues that tend to go away, and then issues can come up years later. I'll illustrate that in the next slide. The next slide. Or actually, maybe after this slide. So the issues that you get from radiation. Again, I can put a lot more specificity on this given time, but pain is one of the biggest problems. Weakness, trouble lifting your head up, trouble using your shoulders and lifting them above head. Numbness, tingling, absolutely a problem. That tightness, that fibrosis of the neck can be very distressing, very uncomfortable. Trouble moving your neck, trouble with full range of motion of your shoulders, trouble opening your mouth, or problems that we can see in head and neck cancer. Of course, speaking and swallowing, extremely common because that whole apparatus that lets you do that is often in that high dose radiation field. Again, trouble opening your mouth, we call that trismus is the medical term for it. Swelling, which is usually in head and neck cancer, is lymphedema. Just like a breast cancer patient would get a big swollen arm, lymphedema patients can have swelling of the face and neck, and then a number of other issues, depression, anxiety, trouble with the carotid arteries, trouble regulating your blood pressure and heart rate, and a number of other things. Next slide. So this is the one that sort of illustrates how these things sneak up and gang up on you. So you're diagnosed, and when you're diagnosed, you already come to the table with various medical issues, particularly if you're an older patient. You're in your 70s, right? You may already have arthritis and diabetes and asthma and cardiac disease and a number of other things. Those set the stage, provide a frame that everything's going to happen when we start treating you. Then you'll often go to surgery. And when we do that neck dissection, we can damage the nerves and you can get trouble, moving your shoulder, moving your neck, opening your mouth, etc., just from that. But then you go to the chemotherapy, radiation, often combined in head and neck cancer. And now you can get neuropathy and trouble walking and trouble with activities of daily living, fatigue, cognitive impairment. Other issues that you develop during surgery, even from the cancer itself, can now get worse. Then you ring the bell, everything's good. Usually most of these problems will settle down and you get back to some semblance of what you were before your cancer journey started, not always back exactly where you were, but then this thing like a wolf is hunting you. And 24, 36, 48 months later, you can start having damage to the nerves, trouble lifting your head up, trouble turning your head, depression, anxiety, and all of these things can get worse. This is why I call radiation the gift that keeps on giving, not to depress people, but to sort of point out that these issues can happen, and then hopefully to equip you with some things you can do about it. Next slide. So this is just showing a patient didn't even have surgery. This was just nasopharyngeal cancer, and you can see how his right scapula from the back is out to the side. That's winged. You can see how his shoulder is depressed. So there's a tremendous amount of nerve damage in here, and he has trouble with a lot of things. Like his big complaint was he couldn't put a suitcase into the overhead in an airplane, and that was really a problem for him. Next slide. This is a patient a little further along. And again, as a doctor, what I'm going to do is show you my worst patients, because showing you my best patients aren't nearly as interesting. So take this for that. But here's a man with pretty bad cervical dystonia. Also has lymphedema of the face. He also has very depressed shoulders and a lot of nerve and muscle damage in here. But his neck is basically fixed here. He can't move it. He can't lift it up. It's really fibrosed and stuck and spasming. Next slide. And again, illustrating the worst of the worst, about as bad as you could ever be with your inability to lift your head up. Usually this starts with just a little neck pain in the back and just, trouble holding your head up through the day. A lot of patients will come to me acting very interested in everything I have to say, which when you're supporting your chin like the thinker, that often means that, you're getting early dropped head syndrome. But there's a lot we can do about this, particularly early. But again, I show you this just to make the point. Next slide. trismus, inability to open the mouth, can really be devastating, right? You can imagine, how do you get food in? How do you brush your teeth? How do you kiss your spouse? You have bad breath all the time, and heaven forbid you have a cancer recurrence. How do we get in there to look for it or treat it? So this is a really big problem that's probably easier to prevent than to treat, although we certainly have treatment options for it, but they don't always work nearly as well as we would like. So it's one of those things to, kind of always be on the lookout for. Next slide. All right, so me as a cancer rehab physician, what do I do? Well, I kind of explain what I do in one of two ways. You can think of me as a sports medicine doctor for cancer patients, or you can think of me as a janitor, basically cleaning up messes. I don't treat the cancer, although I certainly am involved in finding cancer recurrences and that sort of thing. My job is to take care of all the nerve, muscle, pain, function issues caused by cancer, and especially the treatment of cancer. And I do that by pain management. Next slide. I do a number of procedures like botulinum toxin injections to help you get your mouth open, or Botox injections into the neck to help your neck move better or decrease the pain. And I certainly am responsible for trying to find the multitude of issues that you may have and not even know you have, so that we can make sure they are optimally addressed either by me or by a team of other therapists or by your oncologist or any other practitioners that we have. So I sort of serve as the functional quarterback to make sure your survivorship issues are being addressed. Next slide. Again, one of the far and away the most important things that I do is prescribe and monitor physical and occupational therapy. Now, I don't micromanage it. I just make sure that it's being done. There are a lot of special techniques involved in the management of patients with radiation fibrosis that are not known to every therapist. There are a lot of approaches, there's a lot of knowledge. So having somebody who's actually specialized in this, as I'm sure Colleen will testify to, is absolutely critical to getting the best results. Next slide. Speech language therapy. Again, I try to send all of my head and neck cancer patients in for an evaluation as soon as I get them, to make sure we have baseline studies and a baseline clinical evaluation so that we can monitor over time. If you're going to develop a problem, I want to see it coming from a very long way away. And our therapists, again, as Cindy can attest, having the right speech language therapist can make all the difference between singing and not singing. Next slide. And then lymphedema therapy. So pretty much 100% of head and neck cancer patients will have lymphedema swelling, either externally where you can see it, or internally where you can't easily see it without imaging, or both. Lymphedema itself is a fibrotic process. Radiation fibrosis is a fibrotic process. I'm a strong believer that trying to get the lymphedema out, or at least getting it to move, is critical to slowing down some of the issues that happen as a result of radiation. So I incorporate lymphedema therapy again into pretty much every head and neck cancer patient that I see. Next slide. All right, so just a couple little curls before I pass this over to Colleen. One, recognize that radiation is the gift that keeps on giving. I cannot tell you how many patients come in and say, all my doctors said this couldn't possibly be due to radiation, it was too long ago, or that I have fibromyalgia, or I have some other terrible neuromuscular disease. It's not the radiation. So, always assume it's a radiation until proven otherwise. It's kind of a motto that will help keep you out of trouble. It can contribute to other issues in very unexpected ways. So you need to advocate for yourself. You need to convince your doctor that things could be radiation. I had a patient whose doctor for Hodgkin's radiation, where it always hits the heart, say, no, your heart, this is a cardiologist, couldn't possibly be in the radiation field. It's always in the radiation field, back when this patient was treated. So find physicians, physical, occupational, speech language pathologists, and other clinicians. Try to seek them out who understand radiation therapy. And understand, we can't cure you. We cannot make you 24 again. Our goal is not to cure you. Our goal is to make you as functional, as optimized as possible so that you can live your best life. Thank you. Next slide.
My name's Colleen, and I am a physical therapist in Toronto, Canada. And I wear a number of different hats, but one of the ones that I wear most prominently, I guess, is as a physiotherapist for people with head and neck cancer. So I don't have any conflicts of interest or financial disclosures to make, but I will disclose that I am Canadian. So if I interchangeably use physiotherapy and physical therapy, please forgive me, they mean the same thing. Next slide. So even though I'm going to be talking to you about cancer rehabilitation from the perspective of physical therapy, I'd be remiss if I didn't mention that the most effective and the most beneficial cancer rehab really comes as part of a team. And head and neck in particular, as you know, you've heard from Cindy and Michael, is so complex, and there's so many systems affected and so many things that could happen at any stage really of the cancer trajectory. So it's really important that, as many people as you have access to, that you reach out and you try and really approach it from a team perspective. Many of my colleagues, whether it be speech language pathology or the oncologists or massage therapists, are absolutely invaluable to what I do. And like I said, I'll speak to you about some of the things that I do, but again, I just can't stress enough the importance of a very well-rounded multidisciplinary approach to rehab. Next slide. So one of the things I'm going to spend probably the most time talking about is exercise and cancer. And that's because exercise is one of the things that I think probably has the best evidence base behind it when it comes to cancer rehabilitation. It's one of those things that gets looked at more than a lot of other things. And that's for very good reason. It's because it has so many benefits to people, again, no matter what stage of cancer you're at. And of course, it has benefits for everybody in general, but in cancer in particular, it becomes really important to help prepare for cancer treatment, recover from cancer treatment, and in some cases even helps, with things like prevention of recurrence, mostly in things like breast and prostate. But it really is, as I said, a very valuable part of cancer rehab. And it helps with things like fatigue that comes with treatment, nausea, weakness, pain, depression, anxiety. So really wide-reaching in terms of its effects. And probably most importantly is that it helps drive improvements of quality of life. And what we mean by that is that, it helps people come through the cancer treatment better. It helps them recover faster. It can reduce complications. It can just overall leave you in better shape. And I think that's really valuable for most people. Next slide. So, the goals of exercise are going to depend on kind of where you are in your phase of treatment, as well as what your individual goals are. So it's not going to be the same for everybody, even though there's maybe some commonalities between people who are younger versus older, or, have more extensive treatment versus those who have less treatment. But overall, things like gaining back strength after treatment, gaining fat-free muscle mass, and I specifically call out fat-free muscle mass just because it's very common in head and neck cancer to lose a lot of weight quite quickly, because of course it's very difficult to eat and to swallow. And so because of that, most people, when they lose that weight, it'd be great if it was just all your fat, but unfortunately a lot of that is muscle tissue as well. And so that leads to a lot of problems down the road. And when people try to just gain weight back very quickly, it's oftentimes more fat than muscle, which is not really the balance that we want. You may want to use exercise as a means of reducing pain, gaining more energy, and just, again, kind of overall, either maintaining or improving your function and your quality of life. And exercise, again, I'm going to talk about it very broadly, but it could be things like physical activity, which is just, how much you move around on a daily basis and the types of things that you do throughout the day. It could be formal exercise, which might be something like going to the gym or going for a bike ride where, you're intentionally exercising. Or it could be what we call therapeutic exercise, which are specially tailored or specially prescribed exercises to address some of those impairments that you heard Michael talking about. So whether it's a stretch for a shortened tissue or an exercise to strengthen a specific muscle, it's usually things that are a bit more targeted and really geared towards your rehab and recovery. Next slide. So, a question I get all the time is it safe for me to be exercising, especially for people who maybe are, very acute post-surgery, or they're still in the process of getting chemotherapy? And as a general statement, the rule is yes. Again, we look at risk versus benefit, and, there's numerous studies out there showing that exercise can be done very safely with a wide range of patients with cancer. Supervised exercise programs have kind of the strongest evidence, but obviously that's not available to everybody. But group exercise and supervised exercise is always a great option. Even things that some people consider a little bit more high risk, like weightlifting, have been studied in populations like people with lymphedema. And not only is it safe, in most cases, it actually helps reduce the lymphedema. So, there are a lot of ways that you can get exercise in, and certainly the American College for Sports Medicine, which is, a group that routinely puts out the guidelines around exercise for cancer survivors. Their main message is, at all costs, avoid inactivity. It's one of the worst things that you can do is to be inactive during the course of your treatment and during your recovery. As always, there are some precautions. Some of those would apply to anybody. So even if you didn't have cancer, we always tell people to look out for things like a racing heart, becoming faint, short of breath. But then you also have some of those additional considerations, like we've been talking about, where, for example, if you've been through chemotherapy or surgery and you have reduced sensation in your feet, then it becomes a little bit risky if, for example, you're running on a treadmill and you don't have good feeling in your feet, or if you're lifting weights overhead, you don't have good feeling in your hands. Not to say that those things can't be done. Again, it just becomes a precaution that we want to be mindful of. And so that's where having somebody around you who has experience in cancer rehab is really valuable, because they'll know that these types of things are potential issues, and they can help you modify and prescribe an exercise program that takes some of those things into account. Next slide. As I mentioned, it's really important to try and be active and to incorporate exercise at any stage of treatment or post-treatment. It's just, your goals may change a little bit during each phase. So when you've been diagnosed and you haven't yet started your treatment, we do something that we call prehabilitation, which means, we're kind of circumventing and preventing some of the impairments ideally that come up. So in that phase, people are usually focused on increasing strength, increasing endurance, kind of improving your overall fitness. Some people will say, you wouldn't sign up for a marathon without any training. So why would you plan to have, cancer surgery, radiation, chemotherapy, and not kind of try to prepare and get yourself as physically able to do that as possible? When you're in treatment, of course, your body's under a lot of stress already, and we change the goals of exercise a little bit more so to focus on maintaining what you do have. As I said, it can be a very traumatic experience to go through surgery, chemo, radiation, or any combination thereof. So it's usually not a time when we're pushing people to improve their fitness, but really focusing on maintaining, keeping them as active as possible. I know it can be really difficult on some days. You're going to be very tired, very fatigued, and you definitely want to listen to your body and pace yourself. But again, you just don't want to, sit on the couch all day or be in bed all day. You want to make sure to get a little bit of activity in every single day. Now, post-treatment, that's where we can start to refocus on, gaining back some strength, gaining back some movement that you lost, increasing your overall fitness. And whether you're just finished treatment or whether you're 10 years out from treatment, the benefits are still there, and it's never too late to start. Next slide. So some of the things that also help with incorporating exercise into your pathway is finding people that can help support you along the way. Whenever you have a group of people or social supports, it makes it a little bit easier to maintain exercise or to get involved in exercise. And so there's many, many ways you can do that. But some of the ones that come to mind for me in particular, the first one is to look for a fundraising event. A lot of them focus on physical activity, whether it's walking, running, biking. So there you can see some pictures of our Team Headstrong, and that's our head and neck team that participates in the Weekend to Conquer Cancer every year. So we have, a number of clinicians, patients, caregivers, anybody kind of who's interested in supporting head and neck cancer, and we walk or run to raise funds for head and neck cancer, and specifically for our survivorship program at Princess Margaret. Or you can also look to just find a community of like-minded people. So some examples are, I know here in Toronto, we have a dragon boating team that is dedicated to cancer survivors. We have, various like yoga and Tai Chi programs that are dedicated to survivors. And, it's not only do you get the social support of just having people around that can encourage you to exercise, you get the benefit of connecting with people that may have also had a very similar experience to you, and they can understand some of the things that you're going through, especially when you get further out from treatment. And kind of as Michael alluded to, sometimes people think when you're really far past treatment, there's no way that what I'm experiencing now can still be due to my treatment, but it very much can be. And so I think when you connect with people that have been through a similar experience, you really get some support that way as well. Next slide. So speaking a little bit more specifically about what some of the current guidelines are, when it comes to cardiovascular exercise or aerobic exercise, the current guidelines say to try and get at least 30 minutes at a time, 30 minutes combined for the day, at least 3 days a week. So 30 minutes may seem daunting to some people, again, depending on where you're at, depending on your previous level of fitness. And it's okay if you don't get them all in one sitting. And it's also okay if you just work up to that. So that can be your target. And of course, you can go above and beyond that as well. But this is kind of the minimum that we recommend in able to see some of those benefits that we were talking about earlier in terms of reducing fatigue and improving quality of life. The intensity is meant to be moderate, which I know is a very vague term. Moderate simply means that you are pushing yourself and you're challenging yourself a bit, but you're not exhausting yourself. And we'll talk a little bit in a moment about cancer-related fatigue and why you don't want to push to failure or to exhaustion. And in terms of the type or the modality of exercise that you do, I always say the best type of exercise is the one you'll stick to. So if you like walking or running, do that. If you hate walking or running, you don't have to do that. You can do, team or individual sports. You can play with your kids. You can go for a bike ride, go swimming. All of those are excellent options that are going to get your heart rate up and get you experiencing some of the benefits that come along with aerobic activity. Next slide. It's also really important to incorporate resistance training. And that's the type of training that's going to help build back that fat-free muscle mass and that muscle tissue and help you regain your strength. So again, the guideline for cancer survivors currently says at least 2 days a week. Again, you can do more. I would say specifically with resistance training, you really don't need to do 7 days a week. That would probably be a bit excessive. So aiming for at least 2. In terms of the intensity, the guidelines themselves state 60% of your 1 rep max, which again is difficult for someone to know on their own. If you did come see, a physiotherapist or a kinesiologist with experience in cancer rehab, they can help you figure that out. But the main point is that it's something that's going to be challenging, but not impossible to complete. So you'll see there that it also mentions you want to do at least 2 sets of 8 to 15 repetitions. If you can do 15 repetitions of an exercise and you feel like you probably could have done another 15 more, it just means that you're not adding enough weight or enough resistance. So, if you can do 8 and you think maybe you could have done 10 or 12, then maybe that's a more appropriate level of resistance for you. And again, you can do it at home, you can do it at a gym, it can just be with your body weight. For some people, that's enough. And there are actually lots of body weight exercises that we can make very, very challenging. So, you can use free weights, bands, dumbbells, kettlebells, your body. Like I said, there's many, many ways to do it. And then you just progress over time. As it gets easier to do 8 reps, you can aim for 10, or you can try to stick at 8 reps and you can do more weight each time. Just be aware that, if you're exercising muscles around the neck and the shoulder, those are going to take a lot less of a stimulus to grow than muscles, say, in your thigh, because those muscles are just much bigger, the ones in your thigh, So those muscles will need a lot more resistance. Especially when you're thinking about like muscles around the neck and around the shoulder blades, they typically will respond to actually pretty minimal stimulation because they're just smaller muscles. Next slide. And finally, the guidelines around stretching really is about improving flexibility. So, the minimum is 2 to 3 times a week, but stretching is one of those things that you can, and in a lot of cases should do more often, especially if you've had radiation and you're at risk for the radiation fibrosis. It's really important that you keep moving. You try and lengthen whatever muscles are shortened. You're looking for a pulling sensation, not pain. So I usually tell people, the feeling that you get when you pull your fingers back like this, you can feel the pulling in the palm of your hand and maybe down the front of your forearm, but it doesn't hurt. And that's what you're aiming for. You want that stretch, but it should never really be painful. And you want to hold it for up to 30 seconds. Again, that can be your target. If you can't hold something for 30 seconds immediately, you can just work up to that. And typically we tell people, if you're trying to actually make a muscle longer and get rid of some of that stiffness, you can do what's called static stretching, where you do a stretch and you hold it in one position. Whereas if you're getting ready to, say, go for a bike ride or go swimming, you may want to do more dynamic stretching, which is things like, shoulder rolls and hiking your hips up, and that type of active movement that gets you prepared to do more exercise. So both are beneficial. You don't have to do both every day, but again, I think there's some benefit into doing at least something most days of the week. And you can look at activities like yoga, Tai Chi, or you can actually do isolated stretches for specific muscles as well. Next slide. So when you have movement restrictions, obviously, there's some stretches that can help with that. This is really where someone like a physiotherapist or an exercise physiologist can help out, because it's not just about stretching in a lot of cases. You can have movement restrictions for a bunch of different reasons. Shortened tissues or tight tissues can certainly be one of them, but sometimes it's because, a different tissue is weak and is therefore causing a movement restriction. Other times it's because you've had surgery and you've actually had tissues removed. So part of what we do as therapists is really do a comprehensive assessment to look at what are the reasons that you can't move well. And if it's stretching and lengthening, then we can prescribe exercises for that. If it's about strengthening, we can, again, prescribe exercises. We often do a lot of postural retraining. We can do soft tissue work, which is things like something called myofascial release, where we actually help to, use our hands to lengthen tissues. And then there's also different assistive devices that we can recommend. So some of them are to help with lengthening of tissues. So things like a TheraBite, which is something that helps with trismus, that tightness in your jaw. Or it could be something like, looking at bracing or splinting to help with positioning. Next slide. So one other thing I do want to mention is cancer-related fatigue. And the reason why this is really significant is because it's really different from just normal fatigue. It's not the type of fatigue you experience when you just didn't get a good night's sleep and maybe you take a nap and you feel refreshed after. A lot of patients kind of refer to it as just this constant dark cloud that feels like it's hanging over you. So it's really multifactorial. It's caused by, the treatments that you go through, the disease itself, stress, the stress that's involved with a cancer diagnosis, and even things like, maybe you have to commute to the cancer center for radiation every single day for 7 weeks, and things like that all contribute to fatigue. So, something like fatigue, as I said, is very complicated. Sometimes it does actually get, and a lot of times actually, it does actually get worse after treatment. So, I always use the exact same example as Michael about radiation being the gift that keeps on giving. And that's because it's cumulative. So, you're really getting the worst of it towards the end. So cancer-related fatigue often does get a little bit worse before it actually gets better. So while it's kind of in that process of getting worse and kind of coming up the other end, some of the things we do are just around education and energy conservation, looking at things like, pacing, where you incorporate intentional breaks, even if you don't feel tired yet, just so that you incorporate breaks and you don't get to that point of exhaustion. Because once you get there, it's really, really hard to come out of it. So the other strategy around prioritizing is really looking at where you want to spend your energy. I always tell people you've got a finite amount of energy for the day, and you have to think about where you want to use it. So do you want to use it weeding the garden, or do you want to use it with, your family, spending time with people? So if you were someone who loves to barbecue in the summer and you just can't give it to someone else to do, maybe you bring out a stool and you can sit at the barbecue instead of stand, so that it just uses a little bit more energy. So there's lots of tips and techniques we can go through for that. And the picture that you see there is just a clip of a video that I love to give to patients. It's probably the best resource I've ever seen around cancer-related fatigue. So it's by Dr. Mike Evans, and you can find it on YouTube if you just search for Mike Evans and cancer-related fatigue. Takes you through kind of a lot of what I've just talked about in a little bit more detail. And I will give you a spoiler alert if you don't watch the full video. The cure, or the kind of best relief for cancer-related fatigue, is exercise. So aiming for 30 minutes of activity and exercise a day actually does help to reduce fatigue significantly. Next slide. The last kind of impairment and treatment area that I'll talk about, but certainly not, we haven't been able to kind of cover all of them today, is combined decongestive therapy. So that is something that we do for lymphedema, which consists of specialized exercises, lymphatic massage, potentially compression garments or bandaging, elevating. And that can be done by physios, can be done by occupational therapists, nurses, massage. It is a specialized treatment that people have to go and kind of learn. So, I didn't graduate from physiotherapy school knowing how to do this, which again, just kind of reiterates the importance of finding somebody with that specialized skill set. We do also talk a lot about prevention and education. So things like protecting your skin from sunburns, from bug bites, from infection, from restriction. All of those things can make lymphedema worse or bring it on. There's also a number of different therapies that are starting to emerge that we also will incorporate from time to time. So things like using sport tape or kinesio tape, like you see, to redirect the flow of the lymphedema, or doing some soft tissue work to help with scar mobility, help with fibrotic areas, and again, facilitate that movement. And, I know it sounds like a lot to do, but really part of your assessment with a patient is looking at what works for them and what can we incorporate into their lifestyle. So, if you just can't get the hang of lymphatic massage, you can't do it yourself, and you don't have insurance to get it done somewhere else, then maybe we don't need that. Maybe we can incorporate other things into your lymphedema plan that can help. Next slide. And so the last thing I just wanted to leave you with were a number of resources, because again, we've talked really briefly about some of the issues, and there's so many more that we could have talked about.
Thank you to all of our speakers. Those were great presentations. I just want to make sure that our audience knows we are open for questions. You can either ask in the chat or raise your hand, and I will do my best to get through them all. One participant asked, is it possible for trismus to improve after 1 year?
I can answer that. Can you hear me okay?
Yes, we can.
The answer is yes. So interestingly, trismus often comes on acutely immediately post-therapy, and can sometimes just improve spontaneously out to that first year. Certainly, it's often useful to have a therapist help with it. What I'm most worried about is trismus that comes on after that. So when you start getting trismus beyond that 1 year mark, we worry about things like recurrence, osteonecrosis, infection, and a few other things that should be identified and treated. And, it's not unusual for a patient to go from normal mouth opening, which is 35 millimeters, kind of as the general minimum of whatever was normal for you, to literally unable to get a, utensil in their mouth fairly quickly.
Cindy, did you notice if there was anything that you felt like you had still improvement even a year out with your therapy?
Honestly, a lot of things are still, even 4 years out, still improving. I think, lymphedema kind of, for me, has gone up and down in phases. Sometimes, I'm doing really, really well with managing it. Other times, I will have to go back in and see a physical therapist, and they're able to help me out with it. I do have a pneumatic device to help with that, so that makes it a little bit easier to kind of manage that long term. I think some of the mobility challenges and even just strength of my tongue has gotten better. 4 years later, I do still have challenges swallowing and speaking at times. But I still notice where, if with the appropriate interventions from, speech therapists, I'm able to see improvement still 4 years out.
Awesome. Another question for you, Cindy, was what type of vocal exercises did you do to restore your voice after treatment?
A lot that probably you might expect. So really, like, when I started seeing a specialized therapist, kind of went back to basics, just like, what were some of the warm-ups you did when you were studying music in college? Like, let's try those. Let's see how it sounds with your voice, and see how far you're able to open your mouth, and what challenges you're facing, after therapy. A lot of similar therapies that I think a lot of head and neck cancer survivors go through. Swallowing exercises using, I don't know if you've seen, like, it's a little plastic, almost like air bubble thing that you press your tongue up against that can work on strengthening your tongue. A lot of, just kind of overall stretching to get that, oral cavity to open a little bit further. Some breathing exercises to just allow my lungs to expand and, be able to get that breath support that I used to be able to. But a lot of it was just really working through similar exercises that I'd done in the past, and just tailoring it a little bit more to the cancer experience.
Great. Another question for Dr. Stubblefield, is there a scale for radiation fibrosis symptoms?
Yeah, that's a good question. No, not really. It's kind of like yes, no, I think, unfortunately, for most things. So, again, my advice there is consider that everything could be radiation related, and see somebody who can hopefully help you make that diagnosis and direct you to proper treatment.
Perfect. And another question kind of directed towards you. Is there any research or data to show a greater risk of Parkinson's disease after people have been treated with concurrent radiation and chemotherapy?
Not to my knowledge. Parkinson's is a very common disorder in older people. So I've had a handful of head and neck cancer patients with Parkinson's over the years, but I don't think it's at any higher rate than is out in the community.
Yeah, I agree. I haven't heard of anything myself either with patients, but just wanted to see. Another question we had was regarding Prolarin injections, and has anybody on the panel had any experience of other opportunities or other treatments for somebody who's suffering from bilateral cord paralysis? And it might be a little speech specific, but
yeah, I've seen patients have injections as help to kind of fill out the cord, but I do not in any way consider myself an expert on it. But I've seen a handful of patients get it.
We just got a question. After 3 years since radiation and surgery for nasal sinus and palate squamous cell carcinoma, it seems like the person still has partial loss of, I'm guessing, hearing in one of the ears. And can that improve? I would say it's difficult to know from my standpoint in terms of you'd want to get an audiogram and see an audiologist to get an idea of whether it's a conductive loss or a sensory neural loss and how that's going over the treatment. But I also don't know if anybody else on the panel has any comments for that.
I can share my own personal experience. I did have hearing loss, went to an audiologist and got the testing done. Went back in actually last year, just had a double ear infection. And they decided to do the same test again just to see if there was any improvement, and there was improvement. So, that was 3 years later. And, it wasn't a huge loss to begin with, but there was definitely improvement 3 years later.
Awesome. Colleen, I have a question for you. Do you have any recommendations for patients currently undergoing treatment or getting ready to start treatment on what they can do now to help with their symptoms and any potential future side effects?
Sure. So, obviously, there's kind of a common saying around, you wouldn't run a marathon without training. So why would you go through cancer treatment without preparing for it, right? So, depending on kind of when you're diagnosed and what you're about to have done, you may not really have a lot of time to make kind of significant improvements in your physical fitness or your strength. But if there's kind of two quick things I would tell people to do, one is if you do already have any pre-existing swallowing or shoulder problems or neck problems, if you can try and kind of get them looked at even before treatment, just so that, when you go through treatment, it's certainly not going to make things any better in most cases. So if you have something, whether it's pain or a limitation in one of those areas that you can get treated before starting, then it kind of just sets you up for a little bit of a better recovery. And the other thing is we will often, we have what we call a prehab class where we meet with patients before they go through treatment, and we'll do things like go over the trismus exercises, go over all the speech and swallowing exercises that we give out. And I say we, meaning the collective we, not always me necessarily, but me and my SLP colleagues. And we'll go through the exercises just before you get through surgery and radiation and things, so that you have an opportunity to kind of practice them, see what normal feels like, because some of them are not exercises you've probably done before, but just get you familiar with them before you go through the process of treatment, so that as soon as you start treatment, you can get started with those right away.
Awesome. Dr. Stubblefield, how would you advise any of our survivors that are listening today to find a specialist like yourself in the area? You described yourself as kind of the functional quarterback.
Yeah,
love that.
That's it's funny. I'm forever giving talks like this, and I'm forever writing little things, and I have so much trouble with that question because there honestly just aren't that many of us, right? Cancer rehabilitation as a specialty is relatively new, so finding a physician can be challenging. That said, there are a few of us around, so you got to Google us. You got to look. Some of us, like I do virtual visits. So if you reach out and, that interests you, I'm happy to accommodate. In a lot of, head and neck oncologists, radiation oncologists know, the late effects, it's just not what they do full time, like somebody like me. The therapy side is even, is also challenging, but I think getting better. particularly at the larger academic centers, of finding therapists who are knowledgeable in cancer rehabilitation. So anyway, short answer, you got to Google us and find somebody close to you or see somebody virtually.
Awesome. Another question for Cindy. What specific part of your therapy do you think has been most helpful or beneficial for you and your symptoms?
I think physical therapy generally has been the most broad reaching of the therapies that's really helped. Helping with, I had both external and internal lymphedema, which affects, mobility, swallowing, swelling, internally. So, I mean, that helped once I was able to get that under control with, both singing, but also just, being able to turn my head, simple things, being able to look behind me in the car, to being able to go skydiving and not have a tremendous amount of pain. And they worked with me a lot on other, strength and flexibility. And I just think overall that's helped me maintain the best quality of life.
Awesome. And there was just recently a comment about how somebody found Dr. Stubblefield for themselves by being their own advocate, and just wanted to echo that. Even as a physician, I think there's a lot of times that we don't know the other resources or colleagues we have around us, but if a patient asks us in clinic or kind of brings it up, it definitely encourages us to also start Googling and learning about the resources. So don't be afraid to keep asking everybody that you're working with.
And if I can just double down on that, the fact that the only good thing to come out of this pandemic is the fact that most physicians now are doing some degree of virtual visits. So that's really opened it up, where while Colleen can't really do a hands-on therapy for you, I can do a pretty good job of identifying your issues. I try to get patients to come in to see me in person at some point, but it can help direct you to what you need and sort of catalog the issues that you're having or might have.
And I can do a lot too, virtually.
I just want to remind all the people listening and participating, we have about 10 minutes left, so please add any questions in, but I'll keep asking some in the meantime. Colleen, you mentioned the benefits of exercise during treatment. What kind of exercises and how often do you recommend people to do that? And then a second part of that is, what if somebody who doesn't routinely exercise now, what's a place that's safe for them to start? What do you recommend as a starting line for them when they're about to start their treatment?
Sure. So, I mean, there's a couple of ways to kind of think about this. One of them, obviously, if you did have access to an exercise professional in your area or virtually, where we could actually kind of do a baseline assessment and prescribe exercises that are appropriate, because it is really going to depend on your phase of treatment. What your goals might be during treatment are probably going to be very different than what they are going to be after treatment. So that's one thing. Like I said, if there are group programs, they're great to participate in. And a lot of times you don't actually need to kind of participate with the cancer rehab professional the entire time. So what I'll do in a lot of instances, anytime I have access to a specific cancer exercise group, then of course I will refer patients there. But I also see a lot of patients in very kind of rural areas that don't have access to those type of group programs. And so what we'll often do is do an initial assessment. We'll do a lot of education around, the types of things that they can look out for and what they should be watching for. And then they can kind of communicate or participate in other community-based programs. I know for myself, and I can speak for a lot of my colleagues as well, we'll make ourselves available if you're seeing a physio or if you're going to an exercise program in your local community and the person that you're working with doesn't feel comfortable seeing head and neck patients or patients who've had cancer. Like I said, I always make myself available for consults, and I've taken consults from the US as well. So a lot of us out there are really open to kind of connecting with people, because we're constantly trying to increase that number of people that are out there in the community. And as Michael said, it is getting better. It's just still got a long way to go. So, I mean, it doesn't have to be anything fancy. If you just want to start with walking and, do whatever you can do on any given day, especially when you're in the middle of treatment. That's one of the areas where, most people are not really looking to like improve their fitness or improve their strength when they're on treatment. It really is just about doing everything you can to avoid inactivity. So if that's, walking, biking, yoga, whatever you want to do and are comfortable doing, then that's always a great place to start.
Great. Another question for Dr. Stubblefield. Somebody's asking, how good are Botox injections for trismus, and how often do you have to repeat these?
Yeah, so Botox or trismus, just a couple of things. One, the Botox won't open your mouth. What the Botox does is it relaxes the masseter muscle so that Colleen can get your mouth open, right? So it sort of facilitates the therapy to make it easier to stretch because that muscle will want to spasm. You can also do the pterygoids, but that's a much hairier shot, and I don't recommend it for most people. But it's like I kind of joke in clinic when I'm training my residents. It's the equivalent of a flu shot. It's literally just boom, boom, boom. Usually with 50 units each side, and a half cc. They don't hurt very much. I'm literally using the smallest needle we have. But they can be very useful to help the therapist get you open, and they also help with the pain and spasm. You got to remember that the trismus part of it is really because of the ligaments and tendons get foreshortened because that muscle spasming. Take away the muscle spasming, really haven't done anything about the tendons and ligaments.
And how often do you see that patients need to have that recommended?
Yeah, 6 weeks to 3 months. Medicare here only lets us do it every 3 months. Some patients will wear off before that. It's a little different from when we do Botox or central nervous system problems because we don't get that same CNS remodeling, so it wears off when the Botox wears off the receptor.
Perfect. I think we have about 5 minutes left, but I had a question for all the panelists that maybe you guys can comment on. Are there any symptoms post-treatment that should be a red flag to a patient?
Yes. Right. So, I mean, right. So, for me, we're talking about trismus, right? So, while we can fix trismus after a year, very often we can make it better. If you develop trismus later on, we really need to try to look and see what the problem is. If you start developing new weakness, that is a big red flag. Nerve, really kind of any change. But the big things that are making us worry about a new cancer or a jaw fracture, or, I've seen radiation sarcomas come up in patients who've had radiation. All of those sorts of things usually start with pain and loss of function. So when you start getting that, you want to get checked out. And usually, I do it because I see so many people who aren't followed any longer by their oncologist. I'm really their survivorship doctor. So I do a lot of MRIs and PETs and other imaging. But usually the place is to go back to your oncologist and let them check you out. You won't be their first rodeo. This is something they do all the time.
Yeah, I just want to, as a surgical oncologist, comment that I agree. Anything that's new pain or new just doesn't seem right is worth bringing up to anybody, but especially somebody that you're working with who's familiar with your cancer care. Question that might be great for Cindy. Somebody asked, any progress in pneumatic compression therapies or compression in general? I know you were talking about your home device, and then maybe Colleen can add some as well.
Yeah, I really love my home device. So I was set up with that through physical therapy through the hospital where I was treated. And they did a couple of sessions in the hospital first where, they set me up with the garment and fitted everything for me and showed me like how tight it should feel. Just so that, if weight fluctuates, things like that, or, the swelling goes down, how it should feel on your skin. But I've had a lot of really good experience with it. It's made it a lot easier for me to not have to go in for physical therapy quite as often when I have symptoms of lymphedema. I can just kind of pull that out of, have it in like a nice tub in the closet, and it's ready to go, all set up. And, I think they also had somebody from the company come out to my house and like show me how to set it all up and use it and everything. They really make it as easy as possible. It's all pre-programmed, and, so if it's something, I know that like at the time I got it, this was back in 2018 that I would have gotten it. There were a lot of questions about whether insurance would cover it, and my insurance did. So I was very fortunate there. But it's definitely worth exploring if you have a lot of issues with lymphedema. It's definitely, like I said, freed me up from, having to be in clinic quite as often. It makes it easy if, I'm traveling for long periods of time to not have to worry like, oh, am I going to have symptoms while I'm away from home and kind of have to fight through those until I can get back in and see somebody. It's made life a little bit easier.
Yeah, and I don't use a lot of the pneumatic devices, but certainly in terms of compression garments, I think to the kind of external viewer, I'm not sure if you'd notice a lot of the progression, but they certainly are trying to make them slightly more appealing. One of the hard things with head and neck lymphedema, of course, is that if you're wearing compression, it's very, very visible. So I do have a lot of patients who predominantly wear their compression at night, which actually works out pretty well because the edema tends to be quite gravity dependent. So it tends to kind of pool overnight when you're laying flat, and then it often reduces when you're upright during the day. So kind of having something that you can wear at night, but also looking for garments that are, a little bit more, amenable to wearing outside the house. And then some of the other therapies that I started to talk about earlier, where, we're looking at things like using taping maybe to redirect lymphatic flow so that you don't have to wear a big compression garment outside the house. Or, acupuncture is something that is starting to be studied in lymphedema as well. So really, whenever we come up with a lymphedema treatment plan, it's pretty much exactly what Cindy was just alluding to, where it's all about finding kind of the combination of treatments that work for you and for your life. So if someone's okay with wearing a compression garment, most of the day or at night, then we can do that. But if they're really dead set against it, then we can find other ways basically to treat the lymphedema if that just doesn't fit with your specific situation.
Perfect. And another question that I don't know if anybody on the panel wants to comment on: what can you suggest to help with nasal congestion, especially nasal congestion really affecting the sleep, starting after sinus surgery for cancer?
Yeah, I think we're almost better off with one of our SLPs. So, saline washes. Sudafed works great, but you can only use it for a short period of time, and it certainly doesn't help you sleep. Antihistamines, my recommendation, see an ENT. See if, who's more knowledgeable than I am. How about you, doctor?
Yeah, I could. I think a lot of the sinus congestion sometimes is either from buildup and dryness, especially if you've had radiation. And so the best thing to do is these saline rinses. You can either get sprays, or they sell over the counter the NeilMed bottles or any of those sinus rinse type bottles, nutty pop type things. And really that salt solution going into your nose is going to help rehydrate the mucosal membranes. It's also going to help wash out any like pollen debris, crusting you might have, and that can really be symptomatically helpful. I would caution that if it's getting really bad and affecting your sleep, you may want to make an appointment to see your ENT again, just in case, to have a nasal endoscopy and make sure that nothing's going on in there. There's nothing that needs to be debrided a little bit more definitively.
A humidifier is also a really good investment. We had like one of the little portable ones for a long time. It worked great. When we moved into this house, we put in a whole house humidifier, and it has been a game changer.
Another question that came up was somebody is currently going through treatment, it looks like, for radiation for mandibular cancer, or they've received low-level radiation but have a feeling like they're on a boat. Can anybody comment on the level of radiation that can cause vestibular disorders, or is it common to see vestibular disorders after radiation?
Yeah, it's not uncommon, right? So we have a whole line. I don't know if you can comment, Colleen, of the vestibular therapists. It can be very helpful in that situation.
Yeah, so I mean, there is vestibular rehab, the same way that there is cancer rehab. Again, it is a more advanced skill. So I mean, again, I graduated with a very kind of rudimentary knowledge of vestibular rehab, but there are absolutely people out there who can do a more thorough assessment and prescribe some things that can help with that.
It looks like we are actually out of time, and so I apologize for the last couple of questions that we didn't get a chance to, but I wanted to thank all of our survivors and caregivers for attending today. Also, a special thank you to our panelists, Dr. Stubblefield, Colleen, and Cindy, as well as the Head and Neck Cancer Alliance and the American Head and Neck Cancer Society for putting us on. We really appreciate having you all here today, and hope you enjoy the rest of the sessions.